Kimberly.
Should we apply for you too, since you applied for Richard?
Yeah, there you go.
I'm not as good as Richard.
That'll assure applause for you.
No, because we're waiting for Kimberly. It's going to be a thunder and standing ovation.
Well, because we'll be at the end of
You
the
got
day,
it.
right? So I also changed my talk. At 6 o'clock this morning, I was frantically typing, and my husband said, "What are you doing?" I said, "I had this, the typical bureaucratic slides, and I changed my mind at 6 this morning. So hopefully this is for the better." One thing you should know about me is before I came to work for the federal government, I worked at UW in industrial engineering. And so that's kind of the approach or the way I think about these things now. And one of the things, and you may have talked about some of this morning, I wasn't able to be here for all of it, is there really are 3 stages of an industry's evolution. There's the artisan phase, where everyone is doing their own thing and doing it well or poorly. And then there's the standardization phase, and then there's the automation phase. And so you can think about this, if you think about a completely separate industry, think about the auto industry, where the first cars were hand-built by artisans who created their own design. And then we had Ford, and we had the standardization and the assembly line, and now what we have is really automation, where we have machines doing all of the assembly line work, and people basically are pushing buttons, telling the machines what to do. And one thing I think is important to point out, given particularly the last session, is that the purpose of standardization and automation is to reduce variation in quality. So it's not necessarily an improvement. Those aren't necessarily the same things. Now, engineers might argue with me about that, but if you think about the best artisans, right, they might actually, their productivity, their quality of their work might actually decrease under a standardization kind of a model. And so it's just something to think about as we think about where we are in our evolution in these systems. And I know that you talked about this in the first session this morning, and there may be some debate, but I would argue that that the movement in healthcare through from artisan to standardization to automation is really driven by third-party payers, because every patient wants the best artisan. In hospitals, in our system, in the healthcare system, we're really the first recipients of third-party payers. They're also the biggest cost drivers in many ways, and so they really are the furthest along in terms of standardization, that most hospital processes are standardized, and many of them are automated. I was recently in a hospital where the patient flow was automated, so that you get to, if you're a family member with a patient, you see their number on the wall, and it says where they are in the process. It's lovely from the perspective of a family member who's anxiously waiting. Primary care and other physician processes have become very standardized in the past 20 years, but but we are in the phase, I think, where practitioners balk at standardization, and very few processes are automated. It's not really like in most primary care settings. It's not like in hospitals. Behavioral health, and particularly addiction treatment, which is my focus, has actually evolved as a separately funded, separately regulated, separately provided system of care. And now we're at the place where we're trying to integrate into the healthcare system, the healthcare reimbursement system, the healthcare delivery system, and so it's a struggle. In terms of where we are in behavioral health, and particularly addiction, because I think mental health services are actually a little bit ahead in the sort of evolution, we're in a process of trying to standardize, and we have been doing this for probably 20 years, trying to standardize how we deliver addiction services. And so we do this in many of the same ways that other conditions are standardized, but the thing that we have focused our energy on is creating what we call evidence-based practices or programs, and they're relatively complex interventions that when I talk to providers, I sort of liken it to you have to learn It's like learning the Macarena or some actually more complex dance where you have to do all the parts in the right order to the right beat. And that's how we've tried to standardize care in the addiction arena. And so, I mean, we have measurements, but we don't have very good standardized measurements. We've really tried to standardize the actual practice. And again, we have artisans who have balked. And I think that in general, what we have observed in practice is hardly anyone actually does the standardized practice that we've created. And so we still have wide variation. The payment, the reimbursement, the driver of reimbursement for addiction treatment is not really the same as it is for healthcare. As much as 30% of providers still do not accept third-party payment, Medicaid or private pay insurance, and so they're grant-funded, the drivers are different, and not maybe so much towards standardization and automation, more accepting of the artisanal approach. To talk about how these workflows were created under addiction, we really have to think about it. In some ways, it really hasn't been thought of, even though the AMA declared addiction a disease many, I don't know, 75 more years ago. Really, the current system is mostly created out of the 1972 drug wars. When President Nixon declared the war on drugs, they did all the law enforcement part, but they created what is really still basically the treatment system that exists today. And the interesting thing, when I think about this back in '72, the interesting thing that they reasoned around how do we get people into care, into treatment, is that we needed to protect people from treatment from being treated differently or getting being more at risk for law enforcement involvement, right? So we had to protect their treatment records from law enforcement and from misuse. Otherwise, why would anyone go to treatment? Right, if law enforcement, if we're starting a war on drugs, we're going after people. I mean, you can look at the incarceration rates from '72 on. It's an exponential growth curve. So Congress actually passed this law. We know and love it as 42 CFR Part 2, which is the confidentiality regulations for substance use treatment. And if you think about how that system works, really that evolution is sort of in parallel with the criminal justice system and how we address drug use in this country. So now we're in this place. How many years later is that? 72. So
too many.
Many years later. We're trying to move addiction services into the healthcare system, into healthcare settings. And there are so many workflow conflicts, of which this whole issue of confidentiality is just one. So simple things like, what does it mean to deliver treatment? You know, how do we, so medical providers, I mean, you can't leave the doctor's office now without a prescription and feel like you've been treated. Right? But the addiction system really grew up as you avoid all drugs. I mean, there are still self-help groups that say you need to be off everything, even if you have serious psychiatric illness. So that's a set of conflicts of the whole issue of medication versus behavioral therapies. A real conflict comes into place with this whole issue of sharing information, which is the automation part of healthcare in the regular healthcare system these days. I don't know if people remember, I remember when HIPAA first passed, and every healthcare provider you went to, whether it was a pharmacy or whatever, they slapped this 5-page consent form in front of you, and you didn't read it, you just signed it so you could get your drugs and get out of there. And then we've learned since then that that's not necessary. That's not really what HIPAA said, but that was how everyone interpreted it then. And as it's become fully implemented and as we've really had full, well, I don't know if we're really fully there yet, but as we are moving into this era of electronic transfer of information, we realize that HIPAA really was intended to facilitate that flow of information. It's not designed to protect patient privacy or confidentiality of records. But the regulations around addiction treatment confidentiality are. And Richard, when you were talking, I wrote trust and underlined it because you were talking about that. And that's a critical element of any kind of care for any kind of disease. I remember, the TV show House, and Dr. House always said, everybody lies. And I think that if you don't have that ongoing trusting relationship with your physician, everybody does lie. You don't tell the truth about what you ate for dinner last night. You don't tell the truth about how much alcohol you had. I mean, everyone underestimates their bad behaviors. They overestimate how much exercise they get. I mean, that's sort of we all expect that if you work in the healthcare field. And if you think that your information is going to be shared far and wide, then you're definitely not going to tell the truth. In which case, particularly with substance use disorders, but with many other conditions as well, the provider might not even recognize the symptoms because you're not talking about them. And so we have this issue of this conflict of the need for confidentiality, the need for privacy of records so that patients don't have that used against them. And believe me, I'm not going to tell any stories, but I do have actually lots of stories about how patients, when I ran a treatment program back in the 90s, I had a sheriff on my doorstep practically every other week demanding either I know she's in there, or demanding a patient's records. And so well, I don't know, that was the 90s, but it's a long time ago now. But I think the point is that it's still, because the use of drugs is still illegal in this country, that there's always going to be the potential of the information that patients share with their care providers of being used against them. So, as we have begun this integration process, one of the things that's been interesting is the dominant system, the healthcare system, those are the workflows, those are the processes that we have adopted. So it's really been the specialty care system that has tried to adapt. So simple things like how much time you spend with a patient. You don't do, if you have an integrated system, you aren't doing 50-minute hours in that integrated system. You're doing 10-minute drive-by sessions for the behavioral health. And I think that's and the records, if you're in an integrated system, you're using Epic, you're not using one of the specialty care system EHRs. And so we have really been adapting, the behavioral health system has really been adapting their processes to try to be more like the medical system in order to integrate. But I want to leave you with this. I think as we continue to move to more automation in our system, the issue of privacy as well as confidentiality are paramount, not just for substance use disorder treatment, but for all of our health conditions. So if you think about this, as more health data is collected by mobile devices rather than in-office tests, and is collected in a constant flow rather than intermittently, and is stored in the cloud rather than on a single server or on a piece of paper in an office. And as that data is connected between healthcare systems, but also with other public records like arrest records, prosecution records, consumer behavior, and other information, we might want to pause and consider what that means for the patient in terms of their right to privacy, their right to own their own information, their right to be responsible for their own health care, and what it means for us as society when we give away all of those rights.